Okay. Yes. So nice one. Okay.
Okay.
So cataract. And she read on the internet that she can actually do it together in the same day. She's got N+1 cataracts, straightforward case, nothing else going on. How would you, there is a guidance out there, by the way, okay, on the, I think it was published in 20, after COVID, 21, I think, or 2020 or something, mentioning all of that, okay? So definitely have a read, because it's a very hot topic now, it's very debatable, so definitely read it before the exam. So what would be your selection criteria? So when would you offer her best option? When would you not offer her the option? What would you say in this situation?
So basically, any patient that has been referred from optician, they either they have worse than 6-12 vision. So they normally the optician will refer to for assessment for cataract surgery. So during the consultation, I will obviously look at the history for any symptoms of cataracts. How is it affecting the patient's activities of daily living? Any ocular history, medical history. So based on the assessment on examination, looking where's the cataract, how bad is the cataract, what is the visual acuity with vision correction, and also do a fundus examination, a complete ophthalmic exam to counsel the patient on the risk and benefit of the procedure. So it's very much depending on the patient quality of life that's been affected, driving especially, and occupation. These are the things I will take into account. And the cataract surgery is solely.
Let me stop you there for a second.
Yeah.
Yeah, that means just the indications. It's only two. Yeah. So indications would be actually that the cataract is actually indicated as per the NICE guidelines. Yeah, that's one. And that there is no other contraindications, which is the next question. Yeah. Stop. Yeah. So that's the answer to the indications, or what would be your selection criteria? Yeah. So which patient would fit into bilateral sequential imaging cataract surgery? Would be someone who actually needs the cataract and that they haven't got any contraindications, which are the following. Yeah. So what would be your contraindications? When would you not offer them the option?
Contraindications for bilateral cataract surgery.
Yes.
Or contraindications would include any difficult cataract. So, for example, it's a higher risk of endophthalmitis or higher risk of posterior capsular rupture. I wouldn't offer that. Other contraindications include if there is any other concurrent pathology like glaucoma or any other ocular pathology that can affect the visual outcome after the cataract surgery. Other contraindications would be if the patient live alone and without adequate support at home. Because if it's a bilateral sequential, their vision will be affected. They will struggle at home. So that would be a part of my consideration as well.
Fine. Okay. Anything else in mind?
Obviously, bilateral cataract surgery is indicated if the patient is suitable for general anesthetic and if there is any other comorbidities. For example, if it is a challenging case with difficult cooperation, then it could be beneficial from a bilateral sequential cataract surgery under general anesthetic. But there will be another indication.
So what you're meaning to say is, so if you're meaning to say that if she's having 2 general anesthetics for each eye, would be a risk to her health, then just might as well.
Yes.
Do both together in the same GA. You're saying.
Yeah.
Fine. But actually, fine, that's great. But actually, these patients are usually under local anesthetic, obviously. Yeah. So the first choice would be actually local. You wouldn't do routinely a GA for bilaterals, would you?
No. For example, patients with Down syndrome with difficult cooperation under local anesthetic, or
yes. Fine. Fair enough. Fine. Okay.
Other contraindications.
I think you mentioned also. So you mentioned other problems in the eye. You mentioned other health problems in general. If it's a tricky case itself, so primary patient, or difficult positioning, kyphosis, whatever. Previous infective surgery is another one. So any previous operations in the eye, again, we wouldn't do that. Any other comorbidities in the eye. Iodine allergy is another one.
Iodine allergy.
Just to be on the safe side, to be on the safer side, just definitely put iodine in. Other relative contraindications would be patients who are at risk of biometric errors. So if they're very short eyes or very long eyes, if there is any slight risk of any error in the biometry, then that's a big no. Immune compromise, if again we mentioned cooperation issues and increased risk of complications inside the operation, you might actually prefer to do it one-on-one. Ideally, I mean, some now we don't get routinely for all patients, so I'd really read that document well. It's there on Google somewhere. So I think
is it a Royal College guidance on? But is it a Royal College guidance?
Yes, it's college guidance. Yeah, definitely. Published in the UK ISCRS. So I think it was 2020. I think after COVID, and I'm not sure if there's an up-to-date one. I'm sure there is other papers out there, but that is one from the Royal College. So let's stick to that then. Fine. Okay. Surgical consideration. Would you do anything differently for these patients surgically?
For bilateral sequential cataract surgery, it needs to be treated as a totally different procedure during the day. So there's no instrument sharing. So the whole set is different. I will make sure that there's enough staffing in theater to do that. There's enough facilities, anesthetic to do that, and organize the list by doing the whole checklist. Make sure the patient have the proper team brief and then sign out, time out, according to the whole checklist. In terms of the procedure itself, if there is any complication during the first surgery, it is very likely that I have to abolish the second operation if there is any complication during the first eye operation. And then otherwise the techniques will be depending on the case itself.
Yeah. Obviously, all that sort of talk about just make sure that you've cleaned well the conj, iodine, intracameral antibiotics, the standard. There's nothing new there.
Yeah. The only thing different is basically
wound architecture.
Yeah. And I'll need to make sure the biometry biometry reading is accurate. I would need to make sure that it is there's no mistake there, because it will be a never event if I put into the wrong eye in the beginning. So that must be checked, and a new checklist needs to be done on the second eye, like a proper process again.
Yeah. There is another point. I think it's a very important point, is about training the juniors. Yeah. So because imagine if all the cases are done now bilaterally, obviously the consultants will be doing most of those, and then you're running out of cases, to train the juniors. So it does strictly say that if there is a shortage for cases for the trainees to do, then it shouldn't be the standard in your local department. Yeah, if it's going to affect training, then it's not a good idea. Okay. Other consultants can do one eye, and then the junior does the other eye. Although obviously that junior should not be an ST1 or ST2. It should be someone senior, but they can definitely safely do the other eye if the consultant obviously is happy with that and it's the responsibility. But it should be someone senior, basically, ideally.
Right.
But strictly says that it is important that it doesn't reduce access to training facilities. Fine. Again, there's another question about how to counsel or consent this lady. Let me.
Yeah.
I think you mentioned most points, but it just adding a few more points that you need to offer them the option, especially if she asked for it.
Indications.
Yeah. Most consultants, it depends on the consultant, but most of them do the start. Yeah. But if the patient asks for it, then maybe we can come up with that discussion, unless the standard in the local sort of protocol or whatever. Yeah. you should offer the patient alternatives. Yeah. So
Yeah.
if she is asking for bilateral, you should tell her that we can do it separately, which is the standard. That's one. And then obviously, what are the risks? Obviously that if they had an infection, it might go to both eyes, and that might blind them forever. So that's another one. And again, there's a loss of advantage of adjusting the refractive power of it. So let's say you've done one eye, and then there's a tiny refractive surprise or something, then you might adjust it in the other eye. Obviously, if you're doing them both together, then you lose that advantage of adjust power. Again, yeah, just mentioning again all the side effects, all the complications. Just need to spend more time with them, basically. Then the last point was to again offer them again some advice on how to manage at home. So you mentioned if there's enough support at home, that's very important. They might need patching of both eyes afterwards or something, so they might not be able to see at all afterwards. So they need someone with them. They need to make sure that they can put the drops safely and etc. That's about it, really. I think we've gone through all of the document, really. Well done.
All right, thank you.
Thanks. Well done.